This is the Glidescope video laryngoscope, manufactured by Verathon Incorporated, which is in use at the University of Kansas Medical Center. During your education at the University of Kansas Medical Center, you will gain extensive experience in the use of this equipment. Familiarization with insertion technique and endotracheal intubation prior to first use will benefit the novice user. The stylet is inserted into the endotracheal tube and manipulated to either a 60 or 90 degree angulation. The Glidescope blade itself will serve as a guide for the more commonly used 60 degree approach. Both angulations have been compared in clinical trials and have been found to be equally effective in achieving successful endotracheal tube placement. An additional option, not available at the University of Kansas Medical Center, is a reusable Glidescope-specific stylet supplied by Verathon. The novice user may gain experience with this at outside institutions. Note the recessed camera, which protects it from airway secretions and the effects of lens fogging. Also of note is the four-pronged connector port, which relays the video signal to the monitor. Just prior to intubation, the Glidescope is appropriately connected to the monitor. Upon arrival to the operating room suite, the patient is prepared in the routine sequence, having already received intravenous anxiolytic and opioid medication. Standard American Society of Anesthesiologists monitors are applied, including electrocardiogram, non-invasive blood pressure, and pulse oximetry. A standard period of pre-oxygenation is performed, and induction of anesthesia is obtained with appropriate intravenous hypnotic. Ventilation is confirmed prior to dosing muscle relaxant. After an appropriate period to allow for adequate muscle relaxation, we commence with the intubation sequence. Advancement of the Glidescope video laryngoscope is achieved via a midline approach. No lateral tongue displacement is necessary. Careful attention to oropharyngeal anatomy is maintained while inserting the blade to the base of the tongue. Attention is then turned to the monitor, which guides blade placement for optimal glottic view. After satisfactory glottic view is achieved, attention is again directed to the oropharynx as the 60-degree stiletted endotracheal tube is passed toward the base of the tongue. Watching the monitor once again, manipulation of the endotracheal tube is performed such that positive placement in the glottic opening is achieved. Simultaneously to advancing the endotracheal tube through the glottic opening, the stylet is removed. The endotracheal tube cuff is inflated using minimal occlusive pressure. The airway circuit is connected, and confirmatory breath sounds are auscultated over each lung, while noting the end-tidal carbon dioxide on the patient monitor. A second view will familiarize the novice user with airway anatomy. Advancement of the Glidescope into the oropharynx reveals the demarcation between the hard and soft palate. Advancing further reveals the uvula and right, anterior, and posterior tonsillar pillars. Still further advancement reveals a Cormac-Lehane Grade 1 view with full glottic exposure. For comparison, a Mallampati Class III patient is induced and intubated utilizing the Glidescope videolaryngoscope. Pre-induction sequencing with application of monitors, pharmacological agents, and verification of ventilation is similar. Patient positioning is optimized utilizing appropriate support under the upper thoracic and cervical spine, shoulders, and head. While still achieving a Cormac-Lehane Grade 1 view, note the differences in distribution and proliferation of laryngeal soft tissue. In this case, additional endotracheal tube manipulation, along with external posterior superior laryngeal displacement, is necessary to successfully pass the endotracheal tube. In this Mallampati Class III patient, compare the proliferation of laryngeal soft tissue with the Mallampati Class I patient. During your clinical experience at the University of Kansas Medical Center, utilization of Glidescope equipment will facilitate safe airway management in the perioperative period. Prior familiarization will smooth its initial use and facilitate adequate clinical performance.